Function has two components. The first is structural. And in the structural component, we look at genetic or epigenetic compromises. We look for trauma, birth or subsequent. We look for intervention, extractions, appliances. And then we look at the behavioral component, which is the creation of compensatory habits, postural distortions affecting structure, stress responses which affect breathing, and the emotional vicious cycle which drives the above. It is only once we have combined these that we're able to get a total picture of the etiology and the symptomatology, which allows us to devise the best and most stable treatment plan. The reality of life is that we spend 2/3 of our time awake and surviving, and 1/3 attempting to recover from the effects of the 2/3. Under normal circumstances, this is a challenge, and this becomes even more so if that 1/3 is disrupted for whatever reason. Sleep is a perfectly normal physiological function that is designed to allow the body to recover from its daily activities, challenges, and injuries. And in children, it is the time when the majority of growth takes place. Sleep is not a disease and should not require sleep medicine or dental sleep medicine. It is the diseases and the consequences of disrupted sleep that need medical attention rather than sleep itself. It is a highly complex discipline in its own right. So what follows is a small explanation of the relationship between sleep and the airway, as the two are inextricably linked. During sleep, brain neurons shrink to half their size, widening the channels for glymphatic clearance of the accumulated byproducts of brain activity. Concentration is significantly improved, and people who enjoy sound sleep outperform those who don't. Sleep is necessary to consolidate memory. The better you sleep, the happier you are. Lack of quality sleep is related to obesity. Athletic performance is significantly better due to increased recovery during sleep. Pain is easier to manage when you're rested. And of course, the immune system is greatly strengthened through good sleep. Sleeplessness and depression have a direct relationship to each other. So you can see how important quality sleep is. So is it any wonder that with a steady increase in chronic illness over the past 50 years, that doctors began to link poor sleep with increased chronic illness, and come to the decision that sleep disorders were in fact diseased states. So in 1975, two doctors at Stanford University, William Dement and Christian Guilleminault, jointly created the concept of OSAS, obstructive sleep apnea syndrome. They came up with a measurement which they called the apnea-hypopnea index, the AHI, which was purely arbitrary, had no scientific basis whatsoever, and which went on to become the gold standard because there was simply nothing else. Both have sadly passed on in the last couple of years, but not before acknowledging that the AHI was flawed in its concept and did not give a true picture of disordered sleep. Notwithstanding this, it still remains the standard by which OSA and other sleep disorders are being diagnosed. It has no scientific validity whatsoever. Amid the continuing confusion and the disquiet regarding the increasing disparity between negative diagnoses of OSA and the continuing symptoms and ill health of the patients, the gold standard of the AHI was called into question. More and more enlightened professionals, largely in the field of dentistry, saw the misdiagnoses but were not sure what to do, as the medical profession had a stranglehold over sleep disorders. Then, on May the 15th, 2020, a group of 10 international sleep specialists published in the European Journal of Sleep Research an article investigating the science behind the AHI, the apnea-hypopnea index. And as you will see, their conclusions were that the AHI was invalid and should no longer be regarded as the prime diagnostic metric in clinically relevant sleep apnea. This has left the industry in a quandary because it had become a 45-year bastion of diagnosis, and there appeared to be no alternative standard. So, true to form, it continued to be used, and even today is still being used as a benchmark, despite having been negated. And the old excuse was trotted out, well, there isn't anything else. I wonder, maybe it was invalid from the start. It is this kind of entrenched dogma that has kept the sleep profession from progressing beyond nighttime intervention for 45 years. No other branch of medicine or science has remained so doggedly attached to a metric which simply does not provide results. Unless we start to dismantle this dogma, it will probably persist for yet another decade or two, and progress will continue to be hailed in the form of more complex sleep studies, smaller CPAP machines, and more novel masks. It is truly time to move on. So as I mentioned a moment ago, perhaps it was the wrong approach from the start. It won't be the first time, and it certainly won't be the last time, that an idea becomes fixed, only to be disproved later. This is the nature of science. So maybe sleep is not the problem after all. The majority of people suffering from disrupted sleep do not wake up because they can't sleep. They wake up because they can't breathe. This has to be factual, because the two gold standards in treating sleep disorders are both breathing devices. A CPAP is a breathing machine, not a sleeping machine. And an oral appliance is a breathing appliance. Sleep-disordered breathing only applies to people whose daytime breathing is already dysfunctional. I want to really stress this. And the various stages of sleep aggravate the existing condition and cause the person to wake partially or fully. Daytime compensation is common, but it's usually completely unconscious. People don't realize that they're compensating during the day because they're awake. This is not possible at night, and that is the prime reason why people wake up. They wake up because they cannot breathe. And you'll see as we follow this train of thought that the assumption that daytime breathing is okay and that the problem only happens at night is probably the prime reason that minimal progress has been made in this area for nearly 50 years. So now we accept that the concept that sleep disorders breathing is incorrect, and that this only happens when breathing is already disordered, that the process of sleep further exacerbates the problem. The reality is that a person who breathes functionally during the day will have no breathing issues during the night. Therefore, to imply that sleep is the problem will continue to focus the solution on an interventive process during sleep. A far more accurate approach is the understanding that it is the daytime dysfunctional breathing, which is 2/3 of life, which influences the 1/3 of nighttime function and not the other way round. More than 20 years ago, I coined the term breathing disordered sleep, and this is gradually now being accepted as a logical and practical alternative. Modern medicine relies heavily on medical specialists. Of the 90-odd different specialties available, there is no airway specialist. As you will remember from the first module, the airway has 3 different specialties, 2 medical and 1 dental, the ENT, the dentist, and the pulmonologist. Which of these 3 is the right choice? Is being a specialist a guarantee of being right? Consider this. If a concept is fundamentally flawed and you specialize in it, all that makes you is a specialist in a flawed concept. Specializing in something doesn't validate it. I think that's an important point to remember where we are right now. There is, however, a simple and elegant solution, but one that requires a 180-degree change in thinking. As I mentioned earlier, for the past 20 years I've been challenging this notion and proposing that a far more sensible approach would be to look at the problem being breathing disordered sleep. This means that instead of waiting for the problem to occur and then applying an invasive breathing intervention after the event, we would address the issue at its source and identify and treat dysfunctional daytime behavior. Now, this involves paying far more attention to the patient attached to the symptoms rather than to the symptoms attached to the patient. This is healthcare. I have been learning and teaching for close on 60 years and have found that repetition is necessary for people to be able to grasp new concepts, especially when these concepts are outside of their lens of focus or their silo of thinking. What really works well is to say the same thing in different ways, related to different circumstances, but to maintain the essence of the message. And this is where the well-established rule of 3 applies. Rule 1. I'm going to tell you what I'm going to tell you. Then I'm going to tell you. Then I'm going to tell you what I told you. It works well. But, however, it should not be boring. And I promise you this will not be boring. So much of what will follow will repeat and reinforce facts, concepts, and suggestions as to how we can overcome this pandemic of disrupted sleep, far greater, by the way, than COVID-19 will ever be. Nearly 1 billion people worldwide now have sleep apnea, according to a 2018 American Thoracic Society conference held in San Diego. The numbers continue to increase because the cause of the problem is not being identified or addressed. Less than 10% of sufferers are being identified. The total focus is still on nighttime intervention with machines and appliances. There is an acknowledged low rate of success with the current protocols, as you would have seen from the reports and videos from prominent figures in the field. It has become more about testing, about new machines and masks, and treating the numbers than solving the problem. It is not outcome-focused. 45 years, and going backwards, something has to change. Just as the word flu is applied to any form of cold, runny nose, fever, and other symptoms, the term sleep apnea is used for any form of sleep-breathing issue. Breathing issues, in fact, have multiple causes, which simply cannot be grouped under one banner. They also require different approaches, and there is no one-size-fits-all solution. Add to this the word syndrome, and all bets are off, as there are virtually infinite combinations of underlying issues that can create the symptoms presented. The fallback position when diagnosis is not obvious is to call for a raft of tests, hoping that something might appear. Tests can be notoriously inaccurate, with false positives, false negatives, or no obvious outcome at all. So the default option in sleep medicine is to call for a sleep study. Well, the purpose of a sleep study is to see what goes on during a normal night's sleep. How is it possible to regard this as being representative of a normal night's sleep? Look at what we're faced with. How accurate can the results be when you're normally a side sleeper and you have to become a back sleeper? When you're used to a dark room and you're in a bright room? when you're not used to having intrusion, when there's constant monitoring, when you're in comfortable sleepwear and here you've got cables and effort bands. You're used to your home environment. This is a clinical environment. It all ends up being all about the numbers, not the person. Home sleep studies first became available in 2008 and were designed to address several disadvantages of the in-clinic polysomnograms. They were designed to be more comfortable and easier to use as they are done at home. They were far less expensive to administer. They were done in the comfort of one's home and bed, but they had disadvantages. In addition to the fact that they had fewer monitoring channels, over the past 10 years that I've been doing these things, they are subject to multiple failures. Cables come loose, people fiddle with them, they don't attach them correctly, they put the electrodes in the wrong positions. So many people are utterly confused in how to set them up and often make errors which can affect the results. It is simply not possible for all the wires, belts and monitoring boxes not to interfere with the sleep process. There have been improvements in instruments, and the Israeli WatchPat is a far neater device, but also has some limitations due to its fewer points of data collection. It has an optional microphone which attaches to the chest, and the cable runs up the pajama sleeve. The report is a lot slicker than the others, and makes good use of bar and pie charts. Results are interpreted in two different ways. Firstly, the raw data traces are analyzed. Then algorithms are applied to turn these data into reports, some with bar and pie charts which indicate the times and percentages of episodes. It is very unusual for the person scoring the data and the sleep specialist making the diagnosis ever to see the patient. So it becomes a case of treating the numbers and not the person. A typical report will highlight several areas. The AHI, which is still the gold standard metric used to diagnose sleep-disordered breathing, even though we have seen this as no longer being valid. Snoring, heart rate, oxygen saturation or desaturation, pulse, and body position. Different kinds of equipment use different algorithms and present the data in the form of pie charts or bar charts. The catch, however, lies in the fact that nobody other than a qualified sleep specialist is allowed to diagnose from a sleep study, as OSA is termed a serious disease. Now, irrespective of how the data collection is done, the fact remains that the method of predicting the outcome is flawed. And most of this is nothing more than just confirmation of what is already known, but does not address the why. Now we come to a really hot button. One of the major concerns in looking at sleep studies is the ODI, the oxygen desaturation index, which is generally described as a decrease in the mean oxygen saturation equal to or greater than 4% over the last 120 seconds that lasts for at least 10 seconds. Like the AHI, this too is a manufactured metric, which varies from 3% to 4%, is used in some labs and not in others. Now, desaturation occurs when the bound oxygen detaches from the hemoglobin and is free to enter the brain and other cells of the body. Is this not exactly what we want to happen and should be celebrated, not regarded as a disaster? Surely the problem does not lie in the desaturation, but rather in the resaturation process, as it is this resupply process in the lungs that is so important. The saturation-desaturation cycle. Here again we have no definitive scientific accord. just a rough arbitrary range which represents oxygen saturation. Let's look at the definition from Harvard University Sleep Medicine faculty. At sea level, a normal blood oxygen level or saturation, SaO2, is usually 96 to 97%. Although there are no generally accepted classifications for severity of oxygen desaturation, reductions to not less than 90% usually are considered mild. Dips into the 80–89% range can be considered moderate, and below 80% are severe. So if we look at the mechanism of oxygen transport and release, saturation and desaturation should ideally be equal, as the 4 oxygen molecules bound to the hemoglobin are released from the blood into the brain and other cells. The efficiency of this oxygen transport and release mechanism is controlled by the balance in the chemical axis, which keeps arterial blood pH within the limits of 7.45 bond creation and 7.35 bond release. This pH regulation is totally controlled by breathing behavior. From the concept in Model 2 of the hemoglobin express being the transport network, it is easy to see where the saturation and desaturation takes place. Unless the alkaline buffering in the lungs is functioning correctly, we will not have the requisite pH 7.45, and oxygen will not bond to its optimal level. If, at the cell site, the pH is not able to shift to 7.35, the oxygen will not be released. The conductor or mediator in both cases is CO2, which is governed by our breathing behavior. Without going into the complex biochemistry of the process, let it be sufficient to say that the resaturation process in the 4 gas exchange sites is dependent on 4 main factors: a functioning chemical axis of pH 7.35 to 7.45, optimal partial pressure of available oxygen in the lungs, normally 100 millimeters mercury, optimal end-tidal pressure of CO2 in the alveoli of 38 to 42 millimeters mercury, and a ventilation perfusion ratio, VQ, of 0.8. These 4 factors are all dependent on the functionality of breathing in mechanics, dynamics, and biochemical balance. So any reduction in the resaturation of the blood in the lungs is more likely to be a breathing problem rather than anything else. So bearing all of this in mind, let's look at the actual current outcomes. Nearly 1 billion people worldwide have sleep apnea, international sleep experts estimate. A new data analysis presented by ResMed at the 2018 American Thoracic Society International Conference in San Diego indicates that the prevalence of sleep apnea impacts more than 936 million people worldwide, nearly 10 times greater than previous estimates. This is despite tens of billions of dollars that are currently being spent on a process that is obviously not working. And the problem is getting worse. On top of this, the excuses offered by the current supporters of the status quo are that nothing else exists that has been rigorously scientifically investigated and proven, and until an alternative exists, they will stay with what they have. But an alternative does exist, and it fulfills all the requirements of the very tenets of the much-touted science of evidence-based medicine, yet it is not being accepted nor implemented. So now we come to a thorny issue, and something which is completely misunderstood and misapplied. As often happens with 3-letter abbreviations, Careless usage, laziness, and convenience often cause the meeting to become distorted. Conventionally, evidence-based medicine has become to mean that unless a concept or claim is backed by a raft of peer-reviewed, clinically published, double-blinded, randomized, meta-analyzed, Cochrane-reviewed trials, the data is worth nothing. This is simply wrong. Evidence-based medicine is in fact the combination of three individual processes: the skill, experience, and clinical expertise of the practitioner, the patient's satisfaction with the success of the process and the outcome, and finally, the best available, appropriate, published research. I'm going to highlight that. The best available, appropriate, published research. However, in the majority of cases in modern medicine, EBM has come to mean hard published research, as I mentioned earlier, and is often used to discredit many valid observations and outcomes. Despite this fact, anecdotal evidence and proven clinical outcomes are dismissed as lacking any scientific validation. In the words of a well-known British economist, John Maynard Keynes, worldly wisdom teaches that it is better for reputation to fail conventionally rather than to succeed unconventionally. And isn't this the case in so many facets of symptom-based treatment in modern medicine? Whether it works or not, has side effects or not, I'm doing it because that is what everybody else does. Where do we now stand that the four cast-in-stone diagnostic metrics have been shown to be inaccurate or invalid? The AHI has now been debunked as being invalid. The BMI was never intended to be an individual metric. EBM has been perverted to mean research. And SDB is a grab-bag classification for any form of disrupted sleep. And this is still regarded as best practice? Treating the numbers is not a valid basis for a diagnosis of something so complex. One has to see the patient and establish the reasons for the numbers being the way they are. As is common today, reading the numbers causes AHI plus BMI to equal SDB. This formula has caused tens of millions of people to fail and simply give up. The conclusions are largely erroneous because the problem is very different from the symptoms. And although the problem appears to be one of sleep, it is primarily not a sleep issue. We now talk about another contentious issue, and that is one of airway collapse. Much learned discussion has taken place about the function of the airway being like breathing through a series of straws of different diameters. Straws are uniform, are of a fixed diameter, and the internal walls are not subject to congestion. Then some liken airway collapse to sucking a thick milkshake through a straw and watching it collapse. Well, last time I looked, breathing is a two-way process, not a unidirectional pull. Then the parallel is drawn with the Bernoulli and Venturi effects, which give rise to a new metric called the peak crit, which is the critical pressure at which the airway will collapse and needs to be kept open by blowing air in through a PAP machine at that specific pressure. All of this is after the event stuff, which is totally valid in the case of short-term intervention, but which will never ever solve the problem. In reality, much of the obstruction encountered is in the form of congestion rather than compromised structure. Overbreathing triggers an inflammatory response which can cause the tissues to swell. This has the same effect of blocking the airway, but is not due to true structural deficiency. Then you have the question of mouth breathing, which irritates and inflames the sensitive mucosa, causing a histamine and cytokine response which can cause the tissues to swell. None of these conditions usually flag a sleep study response, indicating absence or presence of OSA, yet the person remains symptomatic. All, however, can be significant contributors to UARS, which is upper airway resistance syndrome. In the 20-plus years that I've been involved in the disturbed sleep industry, I have never seen a depiction of sleep apnea in any way other than the person being supine. I find this questionable for two reasons. Firstly, gravity will cause the lower jaw and the tongue to fall back into the airway, causing an obstruction. And secondly, all the papers I have found on sleeping position show the average following statistics. The majority of people sleep on their side. 10% sleep supine, 74% fetal, both left and right, and 16% prone. Do you think it's possible that the high rate of OSA diagnosis could be as a result of people being on their backs most of the night? Now we come to the various stages of sleep, something that can be very accurately determined in a full polysomnogram. As with most metrics, one can at best hope for a close average, because people are so different that the word normal cannot be used to define anything accurately. For ease of discussion, the sleep cycle is divided into roughly 2 equal parts. Half the night is spent in N1 and N2 sleep, which progresses from light through to progressively deep stages. N2 is a newer metric, which combines the previously named Stage 2 and Stage 3. The other half consists of N3, about 20% of deep sleep, which is delta or slow wave, and ends with around 30% of REM sleep. On average, we should have 5 cycles of between 80 and 90 minutes duration, during which the ratios vary, with the biggest difference being in the reduction in non-REM and an increase in REM. REM is rapid eye movement sleep, and the brain is almost as active as when awake. The first period of REM lasts for about 10 to 15 minutes, increasing to about 40 minutes at the end of the last cycle. Sleep latency, which is the time it should take to fall asleep, should be around 15 minutes. You can see the progression to N3 deep sleep, which is predominantly within the first 3 hours. N2 then rises briefly on the way to the first REM cycle, and the rest of the night cycles between N2 and REM. We now come to another debatable metric, because the airway behaves very differently when you are vertical or horizontal, as well as whether you are awake or asleep. Both pharyngometry and cone beam CT are done awake and erect. So is there truly an accurate relationship between this measurement and the actual state of the airway when recumbent and asleep? Metrics too are very different when you're asleep. And as you will have seen when examining the various stages of sleep, many changes can take place. And these changes affect muscle tone, hormone levels, breathing rate and depth, and especially with REM sleep, the paralyzing effect of atonia. The major reason that no further progress has been made over the past 45 years is that nobody has bothered to research alternative ways of addressing the sleep issue. The focus has been on newer and better machines, smaller masks, hypoglossal nerve stimulation, oxygen saturation, and various drugs and devices. This is all after the event stuff, and it ties in with dogma, profit, and inflexibility. The fact that the AHI has never been researched doesn't seem to bother anyone, and it is still being used and defended. Any new suggestion or hypothesis is met with a barrage of objections that no research exists. Therefore, it cannot possibly work. Unfortunately, the existing gold standard in research, the double-blinded, randomized, placebo-controlled peer-reviewed trial, does not always lend itself to every situation. So whilst on the topic of research, let's consider the following. Does it mean that just because a reductionist scientific research paper does not exist, that the observed outcome is invalid? And conversely, does it mean that existing research protocols, which fail to provide a stable result, should continue to be used, just because a paper does exist? Are we not better off being roughly right than precisely wrong? We can then encapsulate the situation quite succinctly. The majority of people do not wake up because they can't sleep. They wake up because they can't breathe. This is a breathing problem that is barely understood by the current orthodoxies because they work around sleep as being the problem. Fractionated sleep is one of the major causes of multiple chronic diseases and is the foundation for sleep medicine as a specialty. The wrong thing is being treated in the wrong way, and this is why the outcomes fall so short of success. Let's revisit the current gold standard solutions for sleep disorders. They are in fact breathing devices, used to try to counter breathing issues experienced during sleep. The existing training in most available sleep courses is all about intervention, as well as the diseases that can arise as a result of fractionated breathing. The situation then exists that the majority of those people who are responsible for the prescribing, fitting, and titrating of breathing devices have no formal education in the science of breathing, its physiology, psychology, or its behavior. But fortunately, there is now a growing awareness among high-profile specialists that the way sleep disorders are currently being managed is simply not working. Here are three of the most respected names in the area of sleep medicine. All are board certified and have held high office in their various associations. All have stated the same facts, in a slightly different way, but are unanimous in their conclusions that something has to change. They agree there is too much focus on testing, that treating the numbers, not the patient, is not the way to go. There is very poor compliance with CPAP. There is lack of interest in following up once the patient has been issued with a machine. Something has to change. In the reference section, you will find a link to video interviews with Dr. Phillips, an annual report from Dr. Rosen, and a commentary from Dr. Malhotra. Let us again review why the current medical system simply cannot handle this problem. It is overregulated by Medicare and insurance. Doctors are limited as to the amount of time they have per consultation. They operate in isolation. There is no in-house team as a support. Their role is to diagnose, prescribe, and refer. They don't have sufficient time to identify the cause as opposed to the symptoms. They use the across-the-desk approach, where my job is to fix you. This is disease management. This is not health care. And let's revisit why the dental team is far better positioned to manage this situation. Airway and sleep disorders are primarily behavioral problems, where the source has to be identified. The secondary issues, the symptoms, are consequences of the dysfunction, not diseases. Dentists and their teams are in a far better position to identify and educate. They have more time and more space. Behavioral change is a team effort, where the structural issues can be addressed at the same time as the source identified and rectified. This is healthcare, not disease management.